My name is Dr. James Young. I'm the Medical Director of Penrose Cancer Center at Penrose Hospital, Colorado Springs, Colorado. I've been here for the last 9 years. The NCCCP, or the National Community Cancer Center Program, is a program of the National Cancer Institute that was started 5 or 6 years ago. In collaboration with Catholic Health Initiatives, approximately 5 or 6 cancer programs, community cancer programs from across the country, were selected to do some innovative work for cancer programs. Basically, trying to make sure communities were served with the same quality of cancer care as academic and research institutions. An important part of community cancer programs is what we call clinical trials. Clinical trials is the vehicle through which we improve cancer care for future generations. Clinical trials are designed to integrate new types of therapy in hopes of moving the field forward and improving outcomes. A typical clinical trial would be for someone who has advanced breast cancer, who agrees to participate in a new cutting-edge therapy. I can think of a patient of mine in her 60s who 18 months ago had progressive disease, was short of breath, and not doing well. She opted to participate on a clinical trial and is still in remission today as a result of this program. Our goal is to try and make that kind of treatment available to more people. There have been huge advancements in recent years in what we call molecular biology, which is basically understanding the human genome. Recently, the National Cancer Institute has funded a project called the Human Cancer Genome Project, whereby cancer tissues are being collected across the country and then their DNA analyzed for specific mutations that give us a bank of data that will help us determine causation of cancer and new targets for cancer treatment. All of this leads to what we call personalized medicine, being able to tailor cancer treatments to the patient's individual subtype of tumor at the level of the DNA. One of the first targeted treatments became available probably 15 years ago for a rare disease called chronic granulocytic leukemia. And it was discovered that one specific mutation is the cause of this disease. And subsequently we learned that one specific drug can reverse the effect of this mutation. A second example would be in breast cancer, where 20% or so of tumors have a mutation that amplifies a gene called HER2/neu. And we've learned that a specific drug can block the effect of this amplification. The drug is called Herceptin, and for that subset of breast cancer patients, it's resulted in an increased likelihood of cure and certainly markedly increased regression of the tumor. And there are probably dozens of additional examples that have come to pass since that time. We couldn't achieve all of this without basic knowledge of the variety of mutations that drive tumors across the country.